Now that we've addressed the six building blocks of health systems, I'd like to specifically address the building block of the health workforce in greater detail now, and the important vital work that they do around the world. There is a global shortage of doctors and other trained health staff. The WHO estimates that in order to achieve global coverage of essential health interventions, we would need more than 2 million more health workers in the world than we currently have, which is an increase of about 70% from where we are now. The healthcare staff that we do have are disproportionately concentrated in high-income countries, leaving many countries with great health needs with extremely small numbers of doctors to meet those needs. Furthermore, wealthy countries hire health staff trained in low-income countries, which is, as we just discussed, a process known as brain drain. Many doctors trained in sub-Saharan Africa are working in wealthy countries. This means that the money that low-income countries spend to educate a health workforce is often lost as skilled doctors and nurses leave for wealthy countries. The WHO estimates that around 20 to 25% of the doctors trained in many sub-Saharan African countries are now working in high-income OECD countries. And these health workers migrate for good reasons, like all of us. They want safe, healthy environments for themselves and their families, and they also want to work in settings where they can effectively serve their patients. More than a quarter of the doctors and nurses in the United States were trained abroad. Within the United States, we do not train enough doctors and nurses to serve our population, but we solve our health workforce problems by issuing visas. This means that the rural areas of the United States that would otherwise be underserved have enough doctors, but it also makes health workforce problems worse in the sending countries. The solution to the brain drain, therefore, lies in the policies of wealthy countries more than in the policies of low-income countries. Short-term medical missions, where rich country doctors go to low-income countries for a week or two, sometimes along with undergraduate students such as yourselves, can make some minor inroads on specific problems, but cannot broadly solve the entire health workforce crisis. Doctors attracted by the promise of medical missions could potentially make a much bigger impact on health workforce issues by pushing the United States to meet the WHO's goal of cutting our dependency on foreign trained doctors in half by 2030. This will require big increases in the numbers of doctors, nurses, and other staff that we train domestically. Many diseases that are major causes of morbidity and mortality for people living in poverty, like diarrhea, malaria, and pneumonia, are reasonably straightforward to diagnose and treat. Lay workers can be trained to identify, prevent, and treat uncomplicated cases of these diseases in a few months. Also, many essential health services, like family planning, don't necessarily require a doctor's level of training to deliver and distribute. Many countries are increasingly looking to community health workers as one potential solution to the human resource crisis by task shifting, as we previously addressed in the mini lecture on global mental health. Ideally, because they serve the communities they are from, community health workers can be advocates for those communities. However, because they are often minimally paid and at the bottom rung of health systems, in practice, community health workers are often exploited workers, given many responsibilities, but few opportunities to shape policy. This is a continuing challenge for global health.